this talk, I'm going to explore some of the challenges around carrying out impactful research in corpus linguistics, and in particular in corpus and discourse studies, and hopefully suggest some ways of overcoming some of these challenges of doing impactful research as well. So this talk is mostly about impact, and the word impact is a bit of a buzzword in academia, but it's also quite controversial and a term that I think has a lot of baggage. So in this talk, I'm going to use terms like impact and engagement on technical terms. So I do impact and to some attitudes or practices that are brought about by research. Engaging others in our research and disseminating it to them is, of course, an important part of achieving impact, but it is quite the same thing in this sense. I decided to talk about impact here because I think that achieving impact, or more precisely, being able to demonstrate that we've achieved impact, is an important part of the higher education landscape. This is certainly the case in the UK and lots of other countries too. So in the UK, which is where I'm based, the last Research Excellence Framework, or REF, which is the major research assessment exercise in the UK, required universities to submit evidence of impact in the form of impact case studies. And that requirement's still in place for the next REF. And while the status of impact among funding councils has changed and is a bit up in the air, I think there's still institutional benefit to demonstrating that our work is impactful, and also in terms of justifying the focus of our work. A lot of the research that we do in CADS is impactful, or at least has the potential to be impactful, but I also feel like it's something that we don't talk about that much. This is particularly the case in corpus and discourse studies, particularly when we compare it to areas like applied linguistics or sociolinguistics, and even some areas of corpus linguistics. And there are all kinds of reasons for this, but I think one of them is that in corpus and discourse studies, perhaps the industries or domains outside of academia that our research links to aren't so clear. The connections between the work that we do and the sorts of domains outside aren't always so transparent. In this talk, I want to address some of the challenges around corpus and discourse studies, and to think about how we might achieve impact. And this will draw a lot on my own experience. And I'm not claiming that I have any expert knowledge or any silver bullet, but I think that there are some insights that could hopefully be useful. So this talk's based mostly on a recently completed project that I worked on in the Centre for Corpus Approaches to Social Science at Lancaster University. The project was titled Beyond the Chekbox, and in it we worked with NHS England to help them to find ways of analysing and making sense of the large amounts of feedback that they receive from their patients. The work was funded by an 𝗚𝗏𝗡 Knowledge Exchange grant. 𝗚𝗿𝗀𝗀𝗀 was the principal investigator, and I was hired as a senior research associate. There was also a PhD student, Craig Evans, who's received some funding to work on the data as part of his PhD. I've chosen to talk about this project because I think that it provides a good example of some of the challenges to trying to achieve impact in corpus and discourse. At certain points, I'll also occasionally refer to some other work that I've done where this is relevant. So the patient feedback we collected and analysed for this project came in the form of online comments posted by patients to the NHS Choices website, and in particular to something called the Friends and Family test. So patients giving feedback in our data were asked, would you recommend this service to friends and family? And then they'd respond by giving a star rating, where 1 star means that they strongly disagree and definitely wouldn't recommend the service, and 5 stars means that they would agree and definitely would recommend the service, with the ratings of 2, 3, and 4 stars somewhere in between. Then in the second section of the form, as you can see on this slide, patients can provide their review in a free text box and explain why they gave the rating that they did. So this second part is more qualitative, and that's the text that our analysis focused on. But I'll also discuss later how we look at star ratings too. In total, we collected and analysed comments posted to the NHS Choices website between 2013 and 2015 And this came to around 29 million words of data, around 228,000 comments. And the comments related to a wide range of areas of provision, from GP practices and hospitals to dentists, care homes and mental health trusts. So once we had our data, the NHS set us 12 questions that they wanted us to answer about the comments that I displayed on the last slide. And here are those questions. And you can see that there isn't really much of a language focus in these. And the questions mainly oriented to the content of the patient's comments rather than their sort of linguistic features. So these weren't necessarily the sorts of questions that as linguists we'd want to ask ourselves, but these were the things that the NHS wanted to find out. And so that it isn't just me moaning about the challenges of impact for the next 40 minutes or so, I'm going to share some findings from the project, specifically relating to the first question about key drivers of feedback, question 2 about between organisations, and then I'll also say a bit about the difference between patients' socio-demographic groups if I have time. So one of the questions that we were asked was, what were the key drivers of positive and negative feedback? And because the comments weren't neatly divided into positive and negative, we had to experiment with different methods to find out what drove patients' evaluations. So one of the, but whatever way we took, whichever approach we took to answer this question, we found that the story here was that patients' evaluations, both positive and negative, were mostly driven by the members' social or interpersonal skills, as opposed to the technical quality of the care that they received. So for example, one approach that we took was to look at 3 of the most frequent nouns in the corpus. So these were care, service and treatment, and then analyze those comments containing those words qualitatively to look at the reasons why patients evaluated them positively or negatively. And you can see from this table that the positive evaluations were driven mostly by staff members' interpersonal skills, followed by communication skills and appointment availability. And it's a similar story for the negative feedback too. So the negative feedback, their criticisms were driven mostly by their perceptions about staff members' personal skills. We can see that technical competence creeps into the negative evaluations here at the bottom, but these are much less frequent than comments about interpersonal skills. And like I said, this trend held pretty much for all of the different perspectives that we took on this question of what drove evaluations. So another thing that the NHS were interested in was what might trigger an urgent review. And as part of that analysis, we looked at concerns that patients themselves labelled as urgent. And we found that the concerns that patients described as being the most urgent were again often to do with staff interpersonal skills. And here's an example of what this type of comment looks like. So one patient wrote, as someone who's worked in the NHS for a long time, I have to say that their attitude towards patients is disgusting and needs to be addressed as a matter of urgency. Staff interpersonal skills are really what drives patients' evaluations. Even when patients appear to be talking about other things like treatment, they're actually talking about staff interpersonal skills. And these concerns also tend to be labelled as urgent more than anything else. And so this is what we've reported back to the NHS, and I'll come back to that shortly. But this wasn't the only way that we approached this question of what drives evaluations. And another way that we looked at this question was to use keywords to compare comments accompanying the different star ratings that patients gave. So to refresh your memories, on the NHS website, as well as leaving comments, patients can also provide star ratings to ask whether or not they'd be likely to recommend the service that they're evaluating to their friends and their family. And as part of, patients gave a rating of between 1 and 5 stars. Then underneath, they can provide their free text comment, which explains the score they gave. And this table shows the different numbers of comments that gave the different star ratings in the data. Not all of the patients gave star ratings, so this isn't all of the feedback, but it does provide a pretty clear picture that it's the very extreme ratings of 1 and 5 that the patients tend to go for. Combine these two ratings account for 81% of cases, while the middling rating of 3, so the sort of score, was particularly unpopular, with only 5% of patients choosing to give this. So this suggests that when patients give ratings, they tend to characterize their experience as being extreme in some way, either as very good or very bad. Another interesting feature is that the most positive feedback tends to be shorter. So feedback rated 1, 2, or 3, which is quite low, has an average word length of around 150 words, whereas feedback rated 4 is slightly shorter at 111 words. And then feedback rated 5, which is the best feedback, was the shortest, less than 100 words on our comment. Once we'd organized our comments according to the star ratings that patients gave, we then compared these sections to each other to obtain keywords that were characteristic of each level of evaluation. So we obtained keywords for comments rated 1, for example, by comparing them against rated 2, 3, 4, and 5 combined. Then to generate keywords for comments 1, 3, 4, and 5 together. And this gave us 5 sets of keywords, 1 for each comments, with some overlaps. So to show these overlaps, I have keywords for each level of evaluation. Here is a Venn. And some of the keywords are pretty obvious, especially the evaluative ones. So for ratings of 1, we have adjectives like rude, worst, unhelpful, terrible, and awful. While for ratings of 5, we have words like best, excellent, efficient, and fantastic. We analysed all 5 sets of keywords, but for this talk, I'm just going to focus on 3 of them. Those with the lowest score of 1, those with the highest score of 5, and those from comments which gave a score of 3 as a sort of medium level of evaluation. So starting with the keywords associated with the lowest rating of 1, and certain forms of punctuation were actually key in these comments. So exclamation marks, question marks, and speech marks were all key in comments rated 1 compared to comments with the other ratings. In this first example, the exclamation mark was used for emphasis, as we'd probably expect. When we look at question marks, we find that they're often involved in rhetorical questions that are used to express dismay, disgust, or exasperation at bad experiences. Incidentally, the number in the brackets next to the comment refers to the level of evaluation that that comment came from. So these are both from comments rated 1. Quotation marks were also key for these comments, as was the use of the quotatives said, asked, and told. And these typically perform a sort of evidential function and end up resembling narratives in which patients either make reasonable requests that are denied, or they're given bad or inconsistent advice or instructions from staff. For example, this last comment reads, "I was called in and once assessed by a new doctor, was told I needed my bloods done, so went downstairs, then told to go back upstairs. What a faffon." And then for the middling ratings, so these were comments rated 3. And remember, this was the least commonly found type of feedback. These comments were characterized by a number of conjunctions, adjectives, and adverbs, which all suggest some form of application. So the adverse conjunctions, but for this rating is mixed, which tends to occur in the phrase mixed bag. And then the keywords generally some and shame are all used to bemoan some aspect of poor service. So what we find here is that middling feedback rated 3 isn't given because patients perceive their experience to be mediocre or average, but it's more to do with the fact that some aspects of care were good and some aspects of care were bad, and they have a sort of balancing out effect. And this also helps explain why an average feedback with this score tends to be the longest, because patients present both sides of an argument in their comments. So now for the best feedback. So these were comments accompanying scores of 5. And the conjunction "and" is key in this category. And this is because the comments often present lists of different aspects of care that patients want to evaluate positively. So in these examples, staff are described as kind, efficient, and very helpful, or the waiting room is uncluttered and well decorated. So this suggests that feedback rated 5 succeeds on multiple criteria. Another notable feature of feedback rated 5 is consistency. So descriptions of service, which is judged to succeed in ways that involve lots of people, both in terms of staff and patients. So keywords like surgery, practice, and team are used to encompass more than one person who works at a GP surgery, for example. The word family is also key in comments rated 5, and this usually indicates that patients who give this highest score haven't just had a good experience themselves, but this reflects the experience of their whole family. So for example, this patient writes, "I've been with this practice a long time and the staff have always served my family well." A similar sort of keyword is years, which is used to indicate consistent good service over a period of many years. So in this example, it's 15 years. And two related additional keywords which reveal this aspect of consistently good service are all and all. So the bottom example reads, "All the reception staff are polite." It's always easy to get. So this analysis oriented more towards language than content. And it wasn't exactly what the NHS had asked us for, but it gave some interesting insights nevertheless, in particular about what tends to result in different scores. A score of 1 can involve a single bad experience, which is often described in detail and is characterized by a feeling of rudeness or being treated unkindly or unfairly. A score of 3 is a mixture of good and bad elements, rather than simply being about an overall mediocre experience. And this isn't something that we were expecting to find. And it appears that overall, when people do write feedback, because they've either had a good or bad experience, or even a mixture of the two. Even the 3s, which make up just 5% of the feedback, tend to contain a mixture of the good and bad. So while this kind of feedback is potentially very useful for practitioners, it's maybe not fully representative of the general population. Finally, a 5 has to involve consistently excellent care provided by entire teams of staff and over a long period of time, multiple family members or friends too. And we thought that all of this sort of pointed to a kind of inequality in the scale, and we weren't expecting to find this. So to receive a rating of 1, a provider has to give poor care just once, on just one occasion. However, to get a score of 5, they have to excel on multiple for a period of time in care provided not just to the patient, but to their extended family as well. In other words, it's probably a lot easier to get a 1 than it is to get a 5. And the reason that we're not seeing keywords like always, all, and years for the worst feedback is probably because if somebody really dislikes a GP surgery or a hospital that much, they're more likely to leave or move to a different provider. So they won't be around long enough to talk about negative long-term experiences. So this is something that we report back to the NHS. And it was something that probably told them about their feedback tool than the feed itself. And while this wasn't strictly what they requested, it was something that they didn't already know, but were interested in when we presented it to them. So when looking at the key drivers of positive and negative feedback, and then when we looked at the characteristic language associated with the different ratings that patients gave, we took a whole corpus approach and looked at all of the comments together. But the NHS were also interested in differences between different types of providers or organisations. And one way that we looked at this was to compare the ways in which different staff members were evaluated. So this table simply shows the frequencies of words denoting different types of staff member. We merged the singular and plural forms, and we also combined references to GPs and doctors. You can see from this that doctors get mentioned much more than anyone else, and then dentists mentioned second most, followed by nurses, receptionists, and so on. And the NHS were interested in how these different types of staff were evaluated and whether they tended to attract more positive or negative evaluation from patients. So this bar chart shows the proportion of positive versus negative evaluations for different types of staff in feedback. And we calculated this by comparing the frequencies of the most frequent positive and negative evaluative collocates that were associated with each staff member. So the blue parts are the proportion of positive cases, and the orange ones are the negative cases. And to make this easier to interpret, I've ordered these from highest to lowest proportion of positive evaluation. So coming at the top with 98% of positive feedback were surgeons. Dentists, paramedics, cleaners, consultants, midwives, nurses, and managers all also do well, all with more than 90% positive feedback. Coming off worse, though, are receptionists, who are positive 57% of the time. So they're still talked about positively more than negatively, just less so than everyone else. A potential issue with this bar chart is that it collapses the evaluative words into a single, and maybe it's helpful to take into account that the words themselves have different meanings. So we also look at which types of evaluative words tended to be attracted most typically to different types of staff. And this table shows what we found. So we have some interesting differences here. Receptionists, positive words, but they also attract the largest number of negative words. So words like useless, rude, unfriendly, and arrogant are all used about receptionists more than anyone else. Further down, pharmacists are helpful more than anyone else, while midwives are exceptional and surgeons are outstanding. So bearing in mind that surgeons and dentists did really well overall with 98 and 96% positive ratings, and bearing in mind that they also attract these really positive words like brilliant and best, we might conclude that the NHS has really good surgeons and dentists who are better than everyone else and should get a pay rise. At the same time, we could also be tempted to report back to the NHS that their receptionists are the worst at their jobs and that they all require substantial retraining. However, apart from being a crude overgeneralization, that would overlook the fact that what we're really seeing here is evidence of different types of patient expectations. So to demonstrate this, it's useful to consider the differences between nurses and surgeons. So nurses were most likely to be described as lovely, while surgeons were most likely to be called brilliant. And although both of these words are positive, they encode quite different types of evaluation. When we looked at 100 cases of nurses being described as lovely, we found that this evaluation was given for things like putting patients at ease, explaining procedures, not rushing, never stopping, answering concerns, bringing them extra cups of tea and being attentive and chatty and friendly and helpful and upbeat and empathetic. However, surgeons get labelled as brilliant by patients when they do things like leave a nice tidy scar, when they're considerate, when they put patients at ease, are honest and don't beat around the bush. And we think that the most telling of these reasons is the one at the end of this list. Patients describe surgeons as brilliant when they feel that there's someone that they can trust their lives with. And we think that this is quite telling. Surgeons carry out operations on patients and quite literally have your life in their hands. So perhaps no matter what nurses do, they're unlikely to attract brilliant or outstanding because they're not perceived as saving someone's life in the way that a surgeon does. In other words, a surgeon saving a life is always going to be seen as more impressive than a nurse bringing someone a cup of tea, and it's these aspects of their roles that patients tend to focus on in their feedback. Another way that we can consider how expectations shape evaluation is by looking at keywords in comments about particular types of staff. And an interesting case to consider here is dentists. So if you remember, dentists came second for overall positive evaluation and were also the second most frequently mentioned staff member. So we had lots of data to work with. So we compared all the text about dentists against all the other comments in the corpus. And a lot of the keywords that we got from the comparison contributed to a recurring type of comment. And I've given an example of this here with the relevant keywords highlighted in red. So in this piece of feedback, the patient says that they had a dental phobia, but the dentist and the practice manager put them at ease and explained everything. Their teeth needed a lot of treatment and they didn't like to smile. But by the end of the treatment, they were a lot less scared of going to the dentist, and now they can smile again. So we're seeing lots of narratives along these lines, with a patient being scared, but then they go to the dentist, the pain doesn't materialize or isn't as bad as they thought it would be. And so they end up having a positive experience and give good feedback. So there's clearly something about dentists that means the patient come preloaded with expectations about what will happen in a way that we don't see with other types of And we think that a lot of this expectation around dentists is to do with the ways that dentists are understood within wider society. If we look at general language corpora, we can see that dentists are discussed in various negative ways. So here are a few examples from the British National Corpus, and none of which paint dentists in a particularly positive light. For example, the first one has a man slumped like a rag doll in a dentist chair. The second has a description of an experience where someone thinks that she's only being examined, but then she actually has all of her teeth taken out and a rubber mask put on her face. And in the third example, someone says that they're squeamish about dentists, while dentists are described as mad in the fourth example. And we can find similar conceptions of dentists in other types of media too. So there are films which portray dentists as sadistic, like Little Shop of Horrors or Marathon Man, which is where these stills are from. And I also typed the word dentist into the stock image bank Getty, and these pictures all featured in the top 100 most popular images, and they're all quite terrifying, and these weren't the only ones. So it's likely that we learn to be scared of dentists from an early age. We pick up on the messages around dentism, so it's no wonder that words like fear, nervous, phobia, scared, and terrified are all key in comments about dentists. But because patients generally don't experience pain, or at least the pain isn't as severe as they expect, their relief is very good feedback. So we're starting to get a sense here that expectations seem to have an important bearing on how different helpers are evaluated. A similar case for the negative evaluations of receptionists. So if you remember, receptionists receive the worst evaluations of all the different types of staff. This slide gives a tiny sample of the types of negative comments that are made about receptionists. So people complain about behaviors like receptionists laughing in patients' faces, interrupting patients, talking about their weekend with their colleagues, refusing to give appointments and asking personal questions. And it's these last two comments that are particularly relevant here, perhaps as they relate to expectations about what a receptionist's job involves. So are receptionists just rude, or is something else going on? Does their behavior receive more scrutiny and comment than doctors or dentists? We've tried to think about possible reasons for why receptionists do so badly. First, we can think about their role. Receptionists act as gatekeepers, which means that they often have to tell people that they can't see a practitioner right away, and that this has the capacity to annoy patients, especially those who might be in pain or distress. Receptionists also administer the bookings, which in all likelihood they don't themselves. In cases, receptionists are required as part of their jobs to conduct what's called triage. So they have to ask questions about the patient's condition, and based on that, they can use a computer system to allocate a patient to a particular doctor based on that doctor's specialism or how urgent. Increasingly common practice, at least in the NHS in the UK, but nevertheless, our corpus of feedback provides evidence that patients can take offence at these questions, interpreting them as receptionists being nosy. We also wondered if perceptions about professional status was a factor. So receptionists are not seen as medical experts, and they aren't able to heal or cure you in the way that a doctor can. So perhaps because of this, a rude receptionist would be given less respect and less leeway than, for example, a rude doctor. And finally, we wondered whether gender was a factor. 94% of receptionists in the UK are female. And again, we thought that there might be expectations that women should be more caring or perhaps nicer than men. With that said, nurses tend to get rated better than receptionists, and 98% of nurses in the NHS are female. So maybe it's a combination of this intersection of gender and perceptions of professional status, along with other factors that we're seeing here. In other words, Joan won't explain the low negative evaluations, but it might play a role. So this has been a bit of a whistle-stop tour of the project, and even then I haven't covered everything that we did. Based on what I presented here, though, we were able to conclude the following and report this back to the NHS. Overall, one thing we found is that commenters tend to give the most focus to the social skills of staff, while discussion around the standard of treatment is less frequent. And there are a number of possible explanations for this. It could be that generally patients are happy with the technical standard of the treatment they receive. On the other hand, it might also be the case that patients feel more qualified to comment on practitioners' social skills than on their technical skills. Whatever the case, it does indicate how social skills play a more important role in measures of patient satisfaction than the NHS originally thought. And this also says something about what the NHS could expect to gain from patient feedback and what it does and doesn't have the power to show. It can be useful for assessing staff interpersonal skills, but it's less helpful if you want to focus on things like staff technical competence. Our analysis also uncovered interesting linguistic nuances in the ways that positive and negative feedback was given. When we looked at the comments accompanying quantitative scores, we found that there wasn't a neat relationship between scores of 1 and 5. While one instance of poor service could result in a score of 1, years of sustained good service, ideally provided to the whole family, was required for a score of 5. So this is something that the NHS would have to bear in mind when interpreting these scores. We also found that patients' expectations played a very strong role in evaluation. People are probably nice about dentists because they're terrified. They're not nice about receptionists because they expect them to be accommodating all the time, and sometimes they can't be. And perceptions about identity factors like staff members' gender and professional status are also likely to play a role here too. So rather than telling the NHS that they need to retrain or fire all their receptionists, instead, what we've told them is that expectations are driving the feedback, and that if we can change patient expectations, that could have an impact on evaluation. So for example, if people were advised in advance that receptionists aren't nosy, but that they're instructed to ask questions as a part of triage, then that might help to improve the feedback that they receive. Or another perspective could be that we regard criticism of receptionists as a kind of personalized criticism of NHS structures. So it's not the receptionists that are necessarily at fault here, but the fact that there aren't enough appointments or the way that triage is conducted, and that these more structural issues would be an area for change. All of this underscores the importance of going beyond quantitative scores alone. And this engagement had to go beyond the surface level of the comments, because when patients are ostensibly talking about things like treatment, they're actually talking about staff interpersonal skills. And they might label complaints about social skills as urgent. So we stress to the NHS the importance of examining the feedback they receive qualitatively as well as quantitatively. And this was something that they weren't doing previously. So the engagement that we did as part of this work was mostly with NHS England. We wrote quite a lengthy report for them and also went down to their London office to present our findings to the patient experience team. We did the same thing for the care quality too. We created a sort of how-to guides and instructional videos for NHS England to help them use the methods we've used to analyze their feedback data in the future. And this is something that they use now. We also tried to take to this audience too. So we published our findings as a book. We gave copies of that book to NHS England. And we also published findings in places where we thought they would be more likely to reach people working in healthcare. So we published an article in the British medical journal BMJ Open, and the journals of the European Association of Language Teachers for Healthcare and the Social Research Association. We also presented our findings conferences where we were the only linguists and we were actually talking. And we also circulated our findings to the public. So we wrote something for the conversation and our research was picked up by a few news outlets, including Mail Online and Metro, and it was also a story on Yahoo News. Lead. Well, overall, the NHS liked the work that we did a lot. They fed back to us that the most sophisticated that they'd seen, and that it had shown them new things about their feedback that they didn't previously know. And this has resulted in material adoption of new practices. In terms of changing their existing practices, our findings have provided confirmation that the friends and family test with the 5-star ratings is imbalanced and that it's skewed towards producing negative results. So on this basis, the NHS are currently in the process of redesigning the tool to come up with something where the scores are more balanced and more evenly weighted. Our bottom-up approach, where we've looked not just at what patients say, but also how they say it, has made them reevaluate their use of algorithms designed to automatically spot certain types of feedback, and then are acknowledging that those types of algorithms aren't particularly well equipped to deal with cases where patients talk about treatment, but they're referring to interpersonal skills, and that those algorithms also don't cope well with rhetorical devices like exaggeration or sarcasm or humor. More broadly though, a major output from the first grant has been a change in organizational culture. So prior to working with us, the patient feedback, this was because the techniques that they had previously used to access the qualitative feedback had proved inadequate for them. And this is now changing though. And the NHS are now placing greater emphasis on the qualitative responses and in taking a bottom-up approach to analysing those too. In fact, to the extent that the training videos that we've provided show how staff how to use corpus methods are now hosted on the NHS's training hub. And it's a resource that analysts are encouraged to use. And the NHS now wants us to help them to look at feedback on cancer in the UK specifically. So that's a project that 𝗷𝗿𝗀𝗀 and I have very recently started working. So I just want to conclude with a few thoughts about the project and the lessons that we took from it. Sorry. First, on a practical level, entering large organisations like the NHS can be very difficult and even intimidating, particularly if we're not familiar with how those organisations work. So navigating these organisations can require skills that as academics and as corpus linguists in particular, we might not have. And universities don't really provide training in things like this too. So having a friendly ally who we can maintain contact with for the duration of our project, friendly inside, can help a lot. But this can be difficult in practice, as people working in these types of organisations often move around a lot, much more than they're perhaps used to working in universities. So in terms of the project that I've described here, our contact at the NHS changed 3 times. And each contact started with the opinion that viable free text analysis of any worth was just too difficult. So we had to win over our new contact each time, and each time convince them of the value of our methods and our analysis. So some persistence may be required. The challenge that's more particular to corpus linguistics relates to the visibility of our approach. So others have said it before, and I think it's the case, that we have a bit of a branding issue in corpus linguistics. As soon as you tell someone that you do corpus linguistics, the very next thing that you have to do is explain what it is. The name isn't particularly transparent, but we're stuck with it for now. But one thing that we can do is perhaps to make the approaches that we use and the work that we do more visible. So in this project and others that I've been involved in with external partners, corpus linguistics has never been their first port of call. It's never been their first choice. So for example, the NHS tried sentiment analysis before corpus linguistics. So part of the challenge for us was showing how our approach differed to the one they tried previously, and of course why we thought it was better. Perhaps one way that we can improve the visibility of our approach is by publishing in journals outside of our disciplinary confines. And this is something that we've tried to do by publishing in medical journals and by attending medical conferences and things like that. But this is a general challenge and perhaps something that we could all do more of. But once we're in, once we have our ally in the organization and we've convinced them, or they've convinced themselves that corpus linguistics is a good fit for what they're doing, we're then likely to face lots of challenges with the research process itself. And it pays here to be adaptable in terms of our methods and our focus. Methodologically, the data that we're working with might not be an ideal fit for our purposes. So we may have to experiment with different approaches, and this can take us beyond our disciplinary norms or boundaries. So in our case, the feedback that we were analysing was neatly divided into positive and negative, and we didn't have metadata about commenters' sex or age, but these were things that the NHS were interested in. So we had to find different routes into the data, and this involved a lot of experimentation and trying out different methods. And this can be particularly challenging when we have a large corpus and lots of results, because we'll have to do a lot of the filtering to get to the results that our stakeholders or partners want, and we'll often have to do that very quickly. In terms of adaptability of focus, we have to bear in mind that our priorities don't always align neatly with our partners or stakeholders. And so the types of questions we have to answer and the types of analysis that we end up doing aren't always particularly interesting linguistically. So for the NHS work, we ended up analysing a lot of content in terms of what it was the patients were talking about. There is, of course, value in taking a linguistic focus and looking at how things are said too, but this might have to be combined with an analysis of content and even looking through the back door sometimes, which was sort of what we did for this project. But in the end, the NHS liked the linguistic insights a lot. So it can be a case that we have to sell the value of the linguistic focus while we're doing the research and convince our partners or stakeholders with our findings. We've taken all of these lessons on board and taken them forward with us in the work that we're doing now for the cancer feedback project that I mentioned earlier. We've also taken on board some of these lessons in some work that we're doing on media representations of obesity that Tony mentioned at the start of the talk, where we're working, for example, with a charity called 𝗬𝗏𝑐𝑖 UK. And the lessons from this project are helping us in a big way to establish and create relationships with those charities. But even if we do all this, even if we make our work visible, establish contacts, exercise adaptability and persistence, there are still no guarantees that our research will be impactful. Doing all of these things well improves our chances, I think, but impact comes in different forms. It's difficult to demonstrate, and it's even harder to predict. Impact is often non-linear, and it can even be accidental. We might carry out research because we're interested in a topic, and then that research is picked up by an individual or an organization, and it changes their views or practices in some way. On the other hand, on the one hand, this can be quite frustrating, but sorry, too soon. On the one hand, this unpredictability can be quite frustrating, but on the other hand, I think it could also give us some cause for optimism. Language and discourse are, of course, social. And the work that we do in corpus linguistics and corpus and discourse studies often addresses real-world concerns and has huge potential to be impactful and to change people's lives. And I think we should draw confidence from this if and when we reach out to people outside of academia with our research, or vice versa when they reach out to us. And there are the references, and there I can stop. So thank you very much.